Next, it's my pleasure to introduce Dr. Neal Seymour, who's Chief of General Surgery at Bay State Medical Center in Massachusetts. He's Professor of Surgery at Tufts University and the Program Director of the Surgical Residency there. Dr. Seymour has published widely on the use of simulation-based training in the operating room. Today he's going to be talking to us about best practices in simulation-based education and training in surgery. Welcome, Dr. Seymour.
Thank you, Mike. Dr. Iwan, Dr. Bittner. We're going to narrow down the topic a bit. I have nothing to disclose. The general topic of best practices in surgical simulation is a pretty big one, but I'd say it's as moving a target as I could possibly speak to. If you look at SAGE as an organization, it has a fairly large interest in simulation, and it has produced some very interesting instruments to both train and certify. And if we regard those frequently represented as best practice types of instruments as examples, you have to add there's a lot more out there, and much of this is being done in relative silence compared to FES and FLS, but it's still there and worthy of mention. It's really the American Board of Surgery that puts the exclamation point on a simulation activity if we look at the evolution of certification and in residency training now looking at mandatory curricula incorporating simulation. The ABS is really a major driver here. So competency-based medical education is, I think, become, to a large extent, virtually synonymous with best practices in education. And when we talk about CBME, we're really referring to is an educational process associated with a progression to some desired level of skill or knowledge. And this works in simulation as well. The idea that there is competency associated with this activity is really a pretty complex construct. That requires definition of what constitutes skillful behavior, and that's much more complex than the traditional surgical paradigm of surgical skill being equated to something that you observe in terms of an everyday activity, how well someone ties a knot or puts in a suture. It incorporates societal expectations and is now a very patient-centric concept. Somehow there has to be value in what's being trained for the patient, and that's definable in clear ways. There is an element of individualization that's inherent in the concept. That is, that although the competency construct may be a constant, the activities that are necessary to achieve it may be highly variable, and different amounts of exposure to educational process may be necessary depending on who's doing it. Anyone who's involved in simulation use in GME knows that the Simulation Center is a major resource. It's available for our trainees on a mandatory basis. The ACGME has defined that as a mandatory activity. They've also used the term objective-based training as part of the process that residents are going to be exposed to. And of course, the American Board of Surgery has to a great extent defined some of the activities that have to happen in the Simulation Center. Fair to say that although we have some competency-based targets that are mandated for our trainees, much of what happens is not competency-based. I have been a particular fan of Dr. Samfi and Dunnington, who in 2011 published an account of a survey of program directors in surgery asking their views on the concept of not progressing a resident or not allowing a resident to go to the operating room based on low levels of performance observed in the simulation lab. And the majority of the PDs who were surveyed felt they would not use that information to prevent progression or prevent a resident from going to the OR, which is a very interesting way to approach the subject of competency. It's almost as if acknowledging that competency in some narrow sense is not important. The standards that are available, looking at the simulation activities that are in common usage, are fairly rudimentary. Not every activity is going to rise to the standards of a program like FLS. However, there are some very highly successful examples of competency-based training and simulation that are available. In some cases, they're available in an off-the-shelf fashion. These are the activities, I think, relevant to the SAGES organization that have focused in large part on laparoscopic training. And I think that those examples have to bring to mind organizations like Southwestern Medical School or the Imperial Medical College, University of Toronto, Southern Illinois University, where the work that has been done in this area is really quite impressive. In some cases, there are successful examples of using remediation types of training activities to actually correct definable performance shortfalls. And these things are the best case examples of how simulation center really can be used and ought to be used in situations where our trainees have the exposure. So what is a best practice? Curriculum-driven competency-based training. Very clearly, that requires measurement. Measurement is a key to successful curriculum. The idea that competency can be defined in some meaningful way, in some cases devolves on being able to observe experts doing things that we would ordinarily train our residents on, measuring their performance and actually having residents reproduce that. Said measurement is the key here. I'm not going to mention a whole lot about validation, and I say that in part because of all the reasons that I have heard not to use simulation activities in some settings where it's really relevant. The one that I find least supportable is the idea that the instruments used to measure performance are not sufficiently validated, or at least not validated at a high enough level to be used for high-stakes testing and summative evaluations. I would counter that by saying that for formative training, that's absolutely not true, that sensible observations regarding educational value made by educational and clinical experts sufficient to use a simulation activity that is deemed very valuable in the course of formative training. And there's a huge difference between doing things for formative training and doing things for summative evaluation. Measurement is absolutely necessary. It's the only way we can trend resident performance. It's the only way we can define competence. This is a sample tool. It's a pen and paper checklisted assessment for small bowel anastomosis. We use this in our institution, and the criterion for competency is 100% completion of all steps. Since competency and evidence seem to be very frequently linked, it's important to make a statement about the evidence supporting best practices in simulation. This is a general statement. In order to do that, understanding what the Kirkpatrick levels are, and this is not related to the level of evidence, but rather to the form of the educational result that is achieved, where it's observed, and of course, level 4, for those who don't know, is an observation regarding the result that is made at the level of a patient outcome. There are very few studies that establish best practices based on clear demonstration of benefit for patient outcome results. And that's the truth of the current state. I would like to see this addressed forcefully in the coming years, but at the present time, most of the evidence that we see supporting a simulation resides at level 2 and 3, which are observations regarding the resident's behavior, observable behavioral aspects that relate to learning what has been taught, and showing that in the behavior resides evidence of learning. And that can be observed both in the clinical world, but also in the laboratory itself. There are some very good examples of simulation and available best practices in training that do impact patient outcomes. And I just wanted to cite Evan's study from Yale regarding ultrasound-guided central venous catheter insertion. This is a particularly important study. It was a fairly large number of subjects involved. It was a randomized controlled trial. And if one looked at the complications of the procedure, the number of punctures that were necessary to successfully access central vein, the avoidance of injuries such as arterial punctures. Clearly, an objectives-based training program that was used was of great benefit, prevented patient injury, it increased the likelihood of successful outcome of the procedure. But to underscore the difficulties of these types of studies, in a very large meta-analysis done by Zendeas, where 50 simulation studies reporting patient outcomes were identified of 10,000 screened papers, only a very small effect was observed. And that was only in comparison to those studies, those studies that had groups that were definable as having no training, as opposed to having alternative non-simulation training where there really was no strong difference demonstrated. This is, I think, a good demonstration of how tough these studies are to do and how patient outcomes are a very downstream effect of the training and may not be the best place to find best practices for the purposes of current use of simulation. In the Kirkpatrick 2 and 3 area, and these are just some sample studies that looked at virtual reality training in the course of randomized controlled trials, where clearly the training had very positive effects on observable trainee behavior, looking at how they do the task that was trained. Very consistently, these studies show that there's a training effect when it's done, both in comparison with non-simulation training and with no training, which the control groups frequently consisted of. So what's available now for training programs who want institute training where there are very strongly supported competency components? I just name a few here, MSTELs, which are the technical skills component of the FLS course. Southwestern Skills Station tasks are a good example, developed by Dr. Scott. Verification of proficiency based on the ACS APDS basic skills modules, been studied by the SIU group and shown to have very positive effects on the skills of trainees who achieve competency levels. To some extent, virtual reality training. I showed a slide that cited a few of the papers that show that. And in flexible endoscopy now in FES, as this is rolled forward, it's based on strong evidence. The fact that this is now a mandatory component of residency training, the board has made a statement about not just the certification, but has established a template for curriculum that's mandatory this year. We're actually looking at, I think, at the beginning of a process that may actually bring these competency components more strongly into residency on a mandatory basis. So a few words on the ACS APDS curriculum. These are the components of the basic skills component. There are 20 of these, and these are available off the shelf. Doesn't require any special rights for access, but trainees can get this information. Simulation lab educators can get this information. Much of it is associated with a competency component, which has been defined with measurement tools that are available, and which it would be hard to justify in the absence of other tools, a simulation program, a residency program, not having these available when these are available very easily with a simple website access and downloading some very simple tools which don't require, in many cases, significant resources to do. A couple words on non-technical and team-based skills. Currently not a mandatory component of residency training, but the ACGME is making strong statements about interprofessional education and how that might be achieved and what the benefit of this is. IPE and teamwork training using simulators is in common use, although this is one of those examples where a competency-based component is probably absent from most programs utilizing it, but there's very strong evidence in other endeavors showing that this is a very effective way to approach the acquisition of teamwork skills that might otherwise be difficult to demonstrate outside of the clinical setting. Patient simulation is a means of delivering a clinical experience with safety to the patient and to the learners. It's something which If done effectively and using effective debriefing methods, we can actually underscore the very important components of teamwork that relate to leadership, that relate to Salas's Big Five, and also communication, the problem of handoffs, and problem solving around clinical problems that might be common, might be very infrequently encountered. Team Steps 2 with its simulation component has been actually utilized in a number of different settings. Team Steps itself with simulation component has been shown to be of value in labor and delivery simulations, cardiothoracic surgery, and in ED. To date, in surgery, the evidence for this are weak, but the prospect of using these tools to address future mandates for IPE in surgical training is very strong. There is only one milestone, as defined by RRC, that actually speaks directly to simulation, actually uses the term simulation, and that is the practice-based learning and improvement number 2 milestone, which I've shown here. I know it's difficult to read, but it actually takes us through a progression of showing skills in the course of doing simulation lab activities, right through at the higher levels and having a teaching role. And I think when the RSC put this together, they envisioned that the simulation lab would be not just a place to learn, but a place for senior residents to provide education and to be evaluated based on the skills they show doing that. However, the medical knowledge and patient care competencies that are defined as milestones can also be addressed with some simulation activities. And that creates a question of how that information is conveyed to those who need to use them to do the milestones evaluations. So it places a responsibility on simulation center staff and educators to have some mechanism to deliver this to the Clinical Competency Committee. Clinical Competency Committee is the agency within the residency that is now charged with doing milestones evaluations on every single resident. Simulation is going to be an important component of this, and I'm actually gratified the RRC and the committee that put our milestones together saw fit to include simulation as one of its components. So, what are necessary practices? The current state, I can make a strong case for basic skills training plus minus verification of proficiency. Curricular efforts toward FLS and FES certification are mandatory, and of course most programs are managing this in different ways. Obviously, there's the certification issue can only be done in specific sites, but certainly training can be done at every single residency program. Simulation-based non-technical skills training. This is a form of training that is in evolution. It's difficult to say how many programs are currently using non-technical skills training in the simulation lab, how many are mandating team steps, for example, for their trainees, but this is an area which is growing. Performance reporting and remediation, practical usages for the simulation lab, information contributing to the CCC mission, the clinical competency mission. This is a practice that falls on simulation educators. And future best practices, it's important to recognize there are at least 3 committees with the American College of Surgeons Accredited Education Institutes Consortium that are working on compendia for best practices in simulation. That is the Best Practices Committee, but also the Research and Technology Committees, which are looking at not just the value of the simulation that's being delivered to the trainees, but the research being done around that. Thank you very much.